Good evening, everybody. It's great to be here. I just have to hook up my computer here. When Cecilia asked me to come, I think she really wanted me to suggest somebody else who could actually do it, they wouldn't have to pay their airfare to come to Vancouver. And I couldn't come up with anybody else who could do it but me. So I wanted to come and do it because I've been involved quite a bit in these legal cases as an expert witness. I was so juiced to be an expert witness at this one case, and I wrote a letter, and then they dropped the charges, or they changed it. So I didn't get to actually go to court. And then, but coming up, I got another one. So I think this issue of criminalization is probably the biggest threat to HIV prevention that we're facing right now. And I feel very strongly as a clinician and a researcher that we need to do something about it. So I'll just give a couple of slides. I was instructed to kind of stick to the facts and talk about the risks of transmission and the medical implications of being HIV positive, and then at the end I'll throw in a few other comments. So I think it's important to know where the HIV epidemic is going globally. So really a lot of the infections occurred in the 1990s, and from a global perspective, even though there's tragic numbers of new cases happening, especially in sub-Saharan Africa still, the course of the epidemic is actually going down. And Canada sticks out as a country that's a relatively low prevalent country still. And this is a slide from BC, and I think really reflects what's happened across much of Canada. So in the 80s and 90s, the blue line represents MSM infections, which were very high. They dropped down around 2000 and have been fairly steady in most provinces and maybe going up slightly. The epidemic among people using drugs really peaked in the mid-1990s, and again in BC has been relatively stable for about a decade and now slowly going down. And finally, heterosexual transmission has been relatively steady. The general principles around sexual transmission, so I'll focus mainly on sexual transmission because that's what most of these legal cases are about. So the risk of HIV transmission varies depending on the type of exposure. So anal intercourse is greater risk than vaginal intercourse. In all cases, a receptive partner is at higher risk than the insertive partner. And a lot of focus has been on oral sex, and either there's no risk in the case of an HIV positive partner performing the act, and extremely low risk in the case of a negative partner performing the act. And a lot of the cases in court are tied up in the risk of oral sex transmission, and basically there's no studies to really prove or disprove this because it's all just self-report, and people have all kinds of sexual activity. So there's never going to be an experiment, but we can say that it's extremely low risk. And the basic principle is even the highest risk activities rarely result in transmission. The court cases always focus on actual numbers and what is really risk and how much risk is acceptable and how much risk is unacceptable. And this is a summary of many studies looking at basically risk per act of sex. And it's broken down into heterosexual and homosexual. And you can see that overall in heterosexual per partner risk, it's 1 in 1,800 to about 1 in 1,300 per time. The highest risk is among gay sex with receptive anal intercourse, and per sexual act, it's thought to be the highest at 1 in 100 or 1 in 200. There's a lot of papers around, and so I just picked out some of the larger review papers just for people copying down references, but a lot of these numbers come from large systemic reviews of the various papers that are out there coming up with these estimates. Now, the factors that modify HIV transmission risk could be broken down into those that reduce risk and those that increase risk. And certainly the reduced risk behavior changes are key, certainly globally, though we understand that people don't always change their behaviors. Clearly, sweeping behavior changes happened around the world to reduce some of this transmission. But the active things that we do are condoms and then undetectable or reduced viral load. Other interventions reducing the risk are considered newer prevention technologies such as pre-exposure and post-exposure antiretroviral prophylaxis, microbiicides, which are used by women in the form of gels and other compounds in the vagina. And the most successful one recently was one that also used antiretrovirals in the compound. And then finally, a lot of bad news, but the odd glimmer of hope about HIV vaccines. But our major tools are condoms and reducing viral load. What increased risk? Well, very recent HIV infections, again related to high viral loads. So when people first become infected, their viral loads spike and then settle down. Being uncircumcised and concurrent sexually transmitted infections, and particularly genital ulcer disease. As far as condoms go, they've really been the mainstay of global HIV prevention for about 25 years, and they're highly effective. There's been a number of studies trying to estimate the protective effect, but basically between 85 and 95% reduction in HIV transmission when condoms are used. And when they fail, it's probably because they're not always used, sometimes incorrectly used, slippage, breakage. But in many studies, it seems that even the most conscientious discordant couples occasionally don't use condoms. And that's usually the story of people who usually use condoms but don't. But they're very, very effective. And again, in legal cases, when condoms are used and applied properly, they reduce the risk of transmission to extremely low levels. These are some of the key references around condoms. What about the impact of undetectable viral loads in HIV transmission? So this is a key thing that certainly Dr. Montaner has been pioneering this and is really now accepted as a very important way forward. So just as a review, what is a plasma viral load? So this is a blood test that came into widespread use in the late 1990s. Now it's an essential tool for managing HIV infection. The test measures the number of HIV viruses in 1 milliliter of an HIV positive person's plasma, and plasma just refers to blood when the cells are taken out. Successful HIV therapy is defined by having an undetectable viral load, and the sensitivity of commercial tests that we now use to find this undetectable viral load is less than 40 copies. But the technology exists to determine even if 1 copy of the virus is there per mil. But it seems that under 40 copies basically is associated with no transmission. There was early evidence of the importance of this, and Dr. Montaner discussed a couple of these, but certainly it was known early on that transmission rates increased during acute infection, and as I mentioned, this corresponds with high viral loads. It was noted early that mother-to-child transmission rates could be greatly reduced from 25% to 2% in one of the pivotal studies using antiretroviral therapy. And finally, it was noted back in the late 1990s that in serodiscordant couples where one person was positive and one was negative, plasma viral load was highly associated with whether people became HIV positive or not. And this is one illustration of that from an early study in Uganda showing that amongst subjects who became HIV positive, there was a heavy association or very clear linear association with the amount of virus that the infected person had at around the time of transmission. Excuse me. All this led to a very controversial Swiss statement in January 2008 that really set the prevention people back on their heels because due to a lot of studies that the Swiss had looked at, they came up with this expert opinion that they said, this consensus statement said that HIV positive individuals who were on effective antiretroviral therapy and did not have another sexually transmitted infection were not infectious. And this created a lot of discussion and and a lot of backlash really by prevention people who thought that would undermine their programs. But I think this has been shown to be quite true. And the impetus for this statement was really because of the legal cases that were coming up in the Swiss country. This is the study that Dr. Montaner referred to that got all the attention in Rome, where they took a large cohort of discordant couples, almost 1,800. Some they started treatment right away, some they delayed the start of treatment, and they looked for the number of infections in the two groups. And this graph is fairly illustrative of what happened. In the people that they delayed the start of treatment, 27 became infected. And those they started treatment right away, only one person. So they stopped the study early because this prospective study showed overwhelmingly that people on treatment with an undetected viral load did not transmit virus to their partner. And this is some of the key references around viral load. The other thing I was supposed to touch on is what it is to live with HIV in 2011. And I deal with a lot of patients from day to day, and I deal with in clinics where attendance has dropped off significantly because most people are doing very well. And a lot of the court cases, again, still refer to HIV as a death sentence. And it's not an easy thing to talk about because when you deal with HIV-positive people, clearly it's a diagnosis that's very difficult for people. It does change their lives, but with modern therapy, it's very manageable. This is a slide that Julio showed that it's a little dated, but showing that when highly active antiretrovirals was introduced, life expectancy went up. I tried to find examples that people could understand in different chronic diseases. So hypertension, for instance, this is how many years left you have after a diagnosis. So if you get a diagnosis of hypertension when you're 20, your life expectancy is about 60 years. But if you adjust that for illness, so healthy life, it's really only 47 years. If you get infected with HIV, it's at 20. The study now, several years old, said that you had 44.7 more years. At age 35, a new HIV positive diagnosis would be 33 years. And I think that the improvements in life expectancy for HIV is improving at a much greater rate than hypertension. So again, these kind of data are bringing in huge cohorts of people that were infected in various times, and to make these type of estimates, you really need to follow people longer. So life expectancy is improving dramatically. This is the kind of treatment that we have now, and if we just go to the bottom of the slide, so modern treatment that really in the mid-2000s, the standard of care now is one pill once a day with minimal toxicity, and we're even noticing quite reduced rates of resistance, and we have more treatment choices. So the modern antiretroviral therapy is improved to, for most people, one pill once a day. As Julio pointed out, I think with the tools we have now, we can reduce HIV transmission to very low levels in Canada. We can continue with our educational messaging. We can continue promoting condoms. Harm reduction strategies work, and they're very underused across Canada for drug users. And HIV treatment really works to reduce transmission. And as HIV continues, in Canada, it's really because we failed to support the prevention interventions that have been proven. And it should be reminded that criminalization of HIV non-disclosure is not one of these proven interventions. The role of public health in infectious diseases. Criminalization of HIV non-disclosure is certainly a serious threat to HIV prevention in Canada and really could undermine decades of progress in prevention. And I feel, my personal opinion, it's based solely on moral arguments and will not prevent HIV infections in Canada. And the criminalization strategy has been allowed really to go forward unchecked without one piece of empiric evidence that it prevents HIV. And for the very rare case of finding someone who is maliciously using their HIV infection to harm others, criminalization of non-disclosure is simply not justified because of many unintended consequences. I've just got my time here, but quickly just going over the many unintended consequences of criminalization. It further stigmatizes HIV. Some people at risk will never get tested. Some people at risk will get tested anonymously and reduces their opportunity for counseling. HIV-positive people will even be less likely to disclose, knowing that the risk of transmission is so small and the potential criminal implications are so large. It will encourage even more anonymous sex, leading to more HIV transmission, no names, no questions, and even could increase HIV transmission in jails if we put people away who are HIV positive. And the worst thing is there's no way to measure the impact of criminalization other than to watching increased rates of HIV and argue about these reasons. And criminal prosecutions are proceeding really in a legal vacuum with no accountability or any connection to these serious public health implications. And I think it's rather ironic that in a field which relies so heavily on evidence to make decisions, there is no evidence that criminal prosecution or the threat of it has prevented even one case of HIV in all of Canada. And my final slide is Pinky in the Brain. And as you know, most people would be familiar with this cartoon, that it starts out every show that Pinky asks the brain, what are we going to do tonight, brain? And he says, the same thing we do every night, Pinky, try and take over the world. So I made up an HIV episode of Pinky in the Brain, and these are the 4 things that the brain would do. He'd erase all information about HIV and how it's transmitted. He'd melt down all condoms, destroy all existing HIV medication, and criminalize HIV non-disclosure to undermine all prevention programs. So to take over the world. So that's it. Thank you.